All right. Now, hopefully, we've already done the balloon lecture, and you guys have a little bit of reference on that. If we haven't done the balloon lecture, this is going to help you out when you come time to do the balloon lecture, so pay attention. So, what are we talking about as being damaged? All right. So, again, we only have three vessels that we got to worry about within our heart: the right coronary artery, the left coronary artery, and the left circumflex artery. Okay. And so, knowing which one gets fed where. Now, I'll tell you again, when I do the balloon lecture, guys, we actually draw on the balloons and we actually draw the chambers and what parts go to what. All right. But I think it's very important to understand that, because if I know what's blocked up, I know what to expect as far as further damage, and I know what to look out for. Okay? And it never made sense to me until I actually had this particular lecture and went, oh, this now makes sense. Okay? Now, that's why I have a lot of bundle branching when there's an anterior wall MI or a septal wall MI versus the lateral wall. They're in shock and they're throwing PVCs like nuts, and the inferior wall where they're throwing PVCs like nuts, and now they're super shocky and their jugular veins are through the roof. They look like death warmed over, essentially. Okay. So again, the three arteries again, and grab my pen here. The three arteries that we're definitely talking about here. Again, this is my right coronary artery, and actually he kind of sneaks around back here. Okay, the left coronary artery splits, left anterior descending, and then this guy over here is the left circumflex, and then he goes back around and he actually kind of goes down right there. So again, one of the things that, by the way, I want to stress, and we're getting to that point where I get to talk about my lovely 15 lead, is that, guys, a standard 12 lead looks at this area, the lateral wall, and this area down here. It does not really look at the right wall, and it doesn't look at the back wall, okay? Which is why when we do a 15 lead, that's going to make a whole lot more sense, because now we're going to get a total picture of the heart. In case you guys go to the cath lab and you see this, the proximal LCA, which is your main. By the way, when that one stops up, I should point that out. When that one stops up, it is a super duper bad thing, because when this one stops up right here, that particular thing, stop and think about everything that gets damaged. The anterior wall, the septal wall, all of this over here. You might have even some inferior entanglement there. So they're going to be having a massive MI at that point. Matter of fact, we call that the widowmaker, right? So we call that the widowmaker. When you have a blockage that's right there, that, again, usually, I can tell you right now, guys, it usually has a really bad outcome. All right. So again, the three parts of the left coronary artery is your proximal LCA, your left circumflex, and the left anterior descending. All right. So again, what areas do they attack? So again, if I've got a blockage in my left anterior descending, it's the anterior septal wall. Left circumflex is usually the lateral wall that's affected. Also the posterior wall. Okay. The proximal LCA is usually you've got an extensive damage to pretty much, if this is my standard 12 lead, yeah, from probably all 6 of those leads are going to have problems. This guy's going to have problems here, and then the middle one there is going to have problems as well, okay? So that's going to be some massive damage when you've got a proximal LCA occlusion. All right, so to give an example here, let's see here. Let's start circling. Yep, that's up. Yep, that's up. Let's see here. Not too bad, not too bad. Depression, 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 depression. So is this a septal anterior infarct? I would say yes, it is. And remember when I kept saying to you guys that these two kind of go together? Most definitely. Most definitely, I would say it's affecting that part of the heart. Let's go ahead and take him to the cath lab. Let's see here. Wow, we could, massive depressions there. Massive depressions there. Ooh, depression there. That's AVR, so and we really don't look at him. Here we go. I would definitely, yeah, this guy's definitely getting a trip to the cath lab, right? So this is the upper lateral leads. There's a lateral wall MI. Let's take a run. All right. And whoa, look at that. Look at all these guys. That's kind of definitely there. Most definitely there. No, not quite sure. Do I see any reciprocal changes? That I got a little bit here of depression. Okay, so that's good enough for me. So this is a septal. This is going to be a septal anterior and lateral wall. So septal anterior lateral leads. It's again very, very, very probably really bad MI that's going on in his left coronary artery. All right. So again, extensive anterior MI, by the way, is septal V1 and V2, anterior V3, V4, and then 5 and 6. Again, usually T-wave inversions or ST changes are common in this type of AMI. And again, we call it the widowmaker. All right. So again, the common complications for this guy, VFib, VTAC, a lot of shock, and this guy right here, 3rd degree blocks, okay? Especially due to the anterior part of that, okay? So we could pretty much have anything happen with this guy. Now, a definitive therapy for anterior wall MI, okay? Keep their blood pressure up, okay? Get them back to keep the pressure up until we can get them to the cath lab and they can open that vessel up, okay? If they're having signs of shock, they're going to need, again, these guys are going to need a cath lab. I will tell you guys, thrombolytic therapy, not really used in the field because, and the reason why, guys, is especially in our area, you're less than 30 minutes from a cath lab no matter where you're at. I mean, you could be out at Cedar Key, I guess, and be an hour away. But even then, you can pretty much be to a cath lab in an hour and still provide the same treatment. We're not talking 2 to 3 hours like it used to be to get somebody to there. Again, if somebody's going to need bypass surgery, obviously take them to where they have a thoracic surgeon available to do that. All right? So the right coronary artery, what am I going to see as far as infarcts? It's probably going to be the inferior wall, okay? More than likely, with a right coronary artery occlusion, the inferior wall, okay? Again, that's your main pumping chamber, main squeeze of the heart. You can also see some lateral wall involvement with them as well, okay? Again, especially the proximal right coronary artery and the proximal descending artery and a posterior descending artery, and that comes off of the left circumflex, okay? So again, this is the right coronary artery goes down to the posterior. That's part of the branch of this. This is the other branch of the circumflex artery in this general area right there. All right. So right coronary arteries, again, the right ventricle posterior wall and the inferior wall. These are the ones that are kind of sneaky. Okay. Again, the good news is that usually your inferior walls are kind of real quick and easy to point out because it's the boot. Again, I've got massive depressions. Massive depression. Good enough to call it a depression. So I've got some major, and I've also got some T-wave flip right here, okay? So, again, this guy's having the inferior wall MI. So what do I look out for with an inferior wall MI, okay? That's the question, all right? So the biggest thing is that we got to check for a right ventricular infarct, and we're going to learn that next lesson, okay? And again, the 12 lead does not usually show it, and that's why we have to do a V4R, okay? And I'm not going to go too deep on that because I'm actually going to talk about that on that next lesson that we're going to talk about. What do I need to kind of look out for though with your right leads? Okay. What I really need to look out for with a right ventricular infarct. Okay. If you have an inferior wall, guys, 50% of the time you're also going to have right wall involvement. So you're not going to get blood out. Again, it's not going to get to the lungs, okay? The insult is happening in this general area right here, okay? So, again, you're going to have trouble breathing with clear lungs. You're going to have jugular vein distension, and they're going to have a relative hypotension, or it could be they're full on out in cardiogenic shock with this, okay? And again, They usually go into right ventricular failure because of this, because of their having the damage to the heart there, okay? So you start getting the backup, all right? So how do you treat this patient, all right? Again, they're going to have shortness of breath. They're going to feel a backup, but they don't back up in their lungs usually. That's left-sided heart failure that they back up in their lungs, okay? So again, presents with a hypotension that does respond to fluid therapy, okay? So even though they got the jugular veins distended, if I know that I've got an inferior wall with a right wall involvement, these guys get a liter of fluid, okay? Now, again, if I start developing rails, stop your fluid. But as long as I don't have the rails, I want to fill up their pipes, okay? Because, again, and use a lot of caution if you use a vasodilator, okay? Very small amounts of either morphine or fentanyl. When I say small amounts, small, and let it. And if we're going to do a nitro, we probably need to do it by a nitro drip. I would say I'm gonna cross that out actually. If you do nitro by drip, I would probably want to A-line in, so I knew their blood pressure. If they have right ventricular involvement, no nitro, none, zilch, or anything else that's going to vasodilate them. You lose that preload, you will never get it back. I'm going to say that again with feeling. If you get that, and you will not ever get it back, okay? Now, again, 1 to 2 liters of fluid. Again, large bore are suitable here. Now, if your posterior wall gets affected, okay, usually with the left circumflex occlusion or a proximal right coronary artery, but these are the guys that hide, okay? They hide. So if I'm seeing a lot of depression in V1 and V4, I want to make sure that I get my 15 lead, which is going to have my V8 and V9 on it. We'll talk about this guy here but in a second, but we can get both at the same time. So that's kind of why we do the 15 lead the way that we do that. All right. So again, where do I put the stickers? I put the stickers mid-scapular line. We're going to talk about that next video, so I'm not going to go into it. But the long and the short of it is the reason I'm seeing reciprocal changes in V1 and through V4 is because I'm not looking at the back wall. That's my V8 and V9. Once I look at the back wall, I go, oh, yeah, that's because this part of the heart is actually dying back here. All right? So again, you're going to have this, and again, the best thing to do is to move the leads and take a look. So by the way, we moved the leads on this one, V7, V8, V9. Whoops, whoops, whoops. Okay, oh, by the way, he's got an inferior wall going on at the same time. Yeah. So how do I change my treatment for this guy, okay? And by the way, you got to look for it, and the story is going to be convincing. The guy that I actually did this slide set with, this gentleman actually, we showed up at it was a New Year's Eve, and this guy kept looking at me going, I'm going to die. And we hooked him up to the monitor, and sure enough, he's got depressions in 1 through 4. And John and I both at the same time, like we were literally working on these slides, and I went, why don't we take a look around back? And sure enough, we took a look around back, and he's having a good old-fashioned posterior wall MI. The good news is he went straight to the cath lab once we got him there and had a little fight with the residents, but that was funny. So again, you're going to have, most of the time, guys, 10% of the population, by the way, for the posterior wall, it's coming off the left circumflex, and I think that's what he was trying to say here. So that's the one that's supplying there. And again, so we take a look, and again, this is a practice EKG. This is actually a standard regular EKG. I've got 2, 3, and AVF. That's good enough for me, boys and girls. And let's see here. We got anything else there? Got a lot of depressions in V1 through V4. Yeah, I want to do a 15 lead on this guy without a doubt, okay? By the way, anytime I've got any type of changes like that, I want to do a 15 lead. And the reason I want to do a 15 lead is I want to make sure that I've got some sort of issue. All right. We talked about these guys already. So the other thing I want to kind of share with you about the bundle branch block and their treatments. 60 to 70% of these folks have pump failure, congestive heart failure, okay? And then 40 for 60% of these guys have a mortality without having reperfusion therapy. That is a huge amount. This is the one that dies on you, okay? So again, the thing is that a bundle branch, it can mimic an acute coronary syndrome. It can hide evidence of it. So again, this is why we fax this one ahead. We let the guy that's got 8 years of training take a look at this, okay? So this thing can produce all kinds of bad things, all right? It can do that. And then the problem is it's critical to reperfuse these patients, okay? But it's harder to identify if they actually need the early reperfusion therapy, okay? Again, I stress. Get them to get that 12 lead or that 15 lead to the doctor, have him to take about it. Last but not least about a bundle branch block. Yeah, forget about the notch, the whole, or the, let's see here, what's my other favorite one? Yeah, that's my other favorite one. Forget about it, okay? If it's greater than 120 seconds, it's got a P wave. Remember, it's going to be either a P wave or it's going to have fib waves in front of it, right? It's going to be supraventricular in origin, and when they, guess what? That's a bundle branch block there, guys, okay? It's going to be longer than 120 milliseconds, okay? At that point, we know that as long as we can figure out that it's supraventricular in origin, we know what it needs to be done, okay? And to reinforce that point, there you go, all right? We already talked about the left right bundle branch, using V1 to do that, and we already talked about our turn signals. All right. My very last thing I want to discuss is pericarditis. Pericarditis, and I'm very sorry, I've got a slide somewhere, I can't find it, and good Lord, I've tried to find it. I will have it by the time we get to class, because it will be quite obvious, okay? There is going to be diffuse elevation in most leads except for AVR and V1. But the rest of them are going to have elevation. So if I've got 9 or more leads with ST elevation, okay, 9 or more leads with ST elevation, more than likely I've got pericarditis, okay? And the final stage is actually the ST segment will invert, all right? So again, it's a really bad idea. ST segments return to the baseline and the T waves become flattened or they invert, okay? Last but not least on this is that, again, it's going to be massive elevations along with a flipping T wave. Pericarditis, I'm telling you right now, you're going to look at it and go, oh, yeah, pericarditis, definitely. So 9 or more leads, guys, 9 or more leads, it's more than likely pericarditis, all right? You're going to have elevations everywhere. You're going to be thinking, oh, this guy's having the big one. Well, he's actually not. With pericarditis, the simple treatment is for this one, the very simple treatment for it is, again, it's a bacterial infection. You got to get ready, though, for your dysrhythmias, okay? And that is one of the problems with pericarditis, is that you'll throw a lot of dysrhythmias, especially if they get bumped or hit or move, or it runs a greater risk. Remember, all that tissue is now irritated, and irritated cardiac muscle likes to beat on its own. And again, if it beats at the wrong time, during an absolute or during a relative refractory period, boom, you just send them into a dysrhythmia. All right, that's going to finish it up for the how to treat patients as far as the very specific things. All right, kind of that putting it all together part. And again, it's going to be confusing at the start. We're going to be practicing a whole lot in class. All right, so we're going to be able to identify these easily, and then you're going to put that 2 and 2 together and then know how to treat them, because that's where we're moving into. We're going past the identification time, and now how do I treat this patient? And yes, the little bumps make a difference. I'll see you guys on the next one.